Dr. Bachmann specializes in STDs and HIV care with more than 15 years experience practicing in both university and public health institutions. She is an expert in the diagnosis and management of STDs, including HIV, and serves as a consultant to the CDC STD treatment guidelines. She has performed research addressing a variety of STD and HIV control issues in both clinical and non-clinical settings. So at this time, we'll have Dr. Bachmann.
Boy, I'm short. Let's see here. I think I can see that screen. Okay, thank you for having me here today to speak with you guys about a favorite topic of mine, STIs, and we're going to cover the older cohorts. Maybe I won't call them elderly. I was suggested to use this topic. So disclosures, I've listed them here. And just to go over what we're going to cover today, we're going to review STIs, or sexually transmitted diseases, by age cohort, but focus in on older cohorts in terms of epidemiology, special considerations, and screening recommendations. We're going to talk about the sexual health framework and then cover a bit about sexual history and counseling. So it sounds like we're going to need to raise hands today because we don't have the clickers. So the questions I want to see how you guys respond. Which of the following statements is correct? Chlamydia rates peak in individuals 30 to 34 years. Syphilis rates in 2015 were comparable in the male and female populations in the United States. Women may be more likely to acquire STIs than men. Or trick infections are more common in younger women compared to older women. So can I see a show of hands for 1, 2, 3, and 4? And thank you for participating. I know that puts more pressure on you than the clickers. So actually, it's number 3. Women are more likely to acquire STIs than men when this has been studied. The thought is probably from a biologic point of view, anatomically, thank you, we're a bit more likely. We have more mucosal surface, etc. But let me go through some of these other issues, okay? So in general, if we look at overall epidemiology of sexually transmitted infections in the United States, the most common reportable infectious disease to CDC is chlamydia at this point. Chlamydia increased in 2016 in all regions of the United States. Gonorrhea rates also increased about 18% in 2016 amongst women and men and across all ethnic and racial groups. And then syphilis rates also increased around 18% in 2016. And when we look at primary and secondary syphilis, which is what we're most interested in because those are the new cases, they're the ones that have the mucosal lesions, the chancres, the rash, they're the ones that are infectious. We see that there was about a 14% increase in individuals that were 45 to 54 years of age, a 25% increase amongst those 55 to 64, and about a 50% increase in those 65 and older. So we are seeing increases in older age cohorts in STIs. Now, if we break down some of the different STIs in terms of age structure and gender rates, let's look at chlamydia first. So these are rates for 2016. There's a couple of take-home points here. First, the rates are highest in women, okay? And while I've made the statement about women being more vulnerable potentially to STIs, at the same time, the interpretation of these data are that women are also screened much more frequently than men, okay? So this is thought to be a case ascertainment bias that's responsible for the majority of this slide. And if you think about it, chlamydia is primarily asymptomatic in men and in women. And we only have screening guidelines for women. So women have higher rates here. Also notice that it peaks in both men and women at age 20 to 24 and drops off precipitously after that. So Why is that? Are there behaviors in our younger individuals it's leading them to have more chlamydia in the population? Are there biologic issues like immunity? We don't get complete immunity to chlamydia, but the thought is we may get some once we get infected. Or there may be network issues. And you'll hear me say this again, STIs and HIV are about networks. Okay, it's who you're having sex with, what is the prevalence in the population you're having sex with. So there's individual behavior, but there's also network-driven consequences that drive prevalence of disease. Now, if we look at chlamydia rates, and this is actually not rates, it's proportion of people who were positive for chlamydia in this study of STD clinics. And this is an STD surveillance network around the country, 75,000 individuals represented on these slides. And this is broken out by reported sexual behavior. So we have men who have sex with men in the dark blue, men who have sex only with women in the middle, and then women. And the bottom line is that regardless of reported behavior, as age increases, the chlamydia proportion positive decreases. The other take home is that men who have sex with men, once you get to that 20-plus age range, have higher rates or proportions positive of chlamydia. And that's consistent with national data that show a heavy burden of STIs and HIV in that population. Now, syphilis is a bit of a different story, and it has been for a long time, and we don't totally understand why, but you'll notice that by age, the syphilis age distribution, while still a bit top-heavy in those younger age groups, it's just a bit more uniformly represented across. You don't get quite that dramatic drop-off with increasing age cohort that you see in chlamydia. And I could have superimposed gonorrhea rates on the chlamydia rates, by the way, that structure. Except the men would have been a bit more represented in the gonorrhea. But the other piece about this, and this is primary and secondary syphilis or early syphilis, is that men are much more represented here in these slides with these rates. And this reflects the nature of our epidemic in the United States amongst men who have sex with men, where the majority of the cases that we're seeing are in that group. Now, having said that, rates are increasing in women, and our congenital cases are increasing as well. Okay, so but for this particular slide, that's why you see this disparity in gender. Now, trick is different. Trick, so we have in red here chlamydia, in purple gonorrhea, and you can see there's a lot more chlamydia than gonorrhea, but for both STIs, the proportion positive decreases by increasing age cohort of the individuals that were screened. But notice how trick in green increases. And this is nationally representative data, likely reflecting the fact that trick is a chronic STD. We think probably could hang around for decades even. We don't know for sure. And also there's not a screening program in place for that STI at this point. And then finally, when we talk about what I call the big daddy STD, because HIV is a sexually transmitted infection for the most part in this country, we see that individuals over the age of 50 are represented still strongly in the new HIV diagnoses, in this case for 2015. And you can see there in red, those are the over 50. And then if we look at new cases of incident cases of HIV, while overall cases are going down, like men who have sex with men and other age groups, the rates are increasing in men who have sex with men in the older age groups as well, okay? And when we talk about people living with HIV, now fortunately our drugs have improved. People are living almost normal lifespans if they're able to take the drugs and tolerate them, and that's all good news. But because of the increasing prevalence and people are aging with HIV, almost half the population with HIV in the country now are over 50. And that has a lot of implications for management of comorbidities, for the issues that the previous speaker spoke about, drug interactions with all the other medications that are required with the antiretrovirals, et cetera. So what does age have to do with any of this? Do older people even have sex? I guess there was a point in time when I thought the answer to that was no, you know. That didn't happen. But before I go into some data on this, let me just ask you once again to commit yourselves to answering some questions here. So which of the following statements here is false? Over 40% of men aged 70 and above report having engaged in vaginal intercourse over the last year. Approximately half of women aged 60 to 69 masturbate. Over 10% of women aged 40 to 49 have engaged in receptive anal sex in the last year. Or none of these statements are false. Okay, y'all are yelling. That's maybe the more efficient way. Everybody's saying 4, and that is correct. All of those statements are correct. So this is a busy table, so I've tried to highlight a bit. You've got this represented, I think, one time in your printout. But this table represents, this is the National Survey of Sexual Health and Behavior that the University of Indiana conducts periodically. And it is a population-based survey. And these are the percentage of Americans reporting certain sexual behaviors in the past year. So we've got about 5,800 people that reported. If we look at I've got it divided up 50 to 59, 60 to 69, and 70 plus by age cohort. So masturbation, it decreases as age increases, but still quite common. So, 70 plus, you have almost half the men masturbating, about 30% of the women, okay? If we go down to vaginal intercourse, once again, the activity decreases as age increases, but still almost half of the men, 70, or 40% of the men, 70 plus, 22% of the women report having engaged in that activity in the last year. And then anal sex, which is reported less commonly, it's still occurring, okay, even up to those later age spectrum. So the point is that we're sexually active throughout our lifespan. We're sexual beings. That's to be expected, right? And so, therefore, I guess this really shouldn't be surprising, but I think that there are a lot of assumptions, so that's why I illustrate this with some actual scientific data. So let's do another question. Which of the following statements is true? HIV infection tends to be diagnosed at an earlier stage in older individuals. Sexual activity is a common topic of conversation between older individuals and their primary care provider. Fewer older individuals use condoms, American older individuals use condoms to protect themselves during sexual intercourse, or none of the above. 3, that's right. So these are data from that same survey, and the take-home point is you see reported condom use at last, this is the percentage of past 10 vaginal intercourse acts that included a condom. And you can see that percentage reported decreases by increasing age cohort, where it's very, very low in the 61 plus age group. Now, one may say, well, those individuals are probably stably paired, they're monogamous, they don't need the condoms. Okay, but that's not entirely true, because this group went and they honed in on a certain segment of the population that they were surveying. They looked at 122 men and 80 women who were 50 or above, who had engaged in penile vaginal intercourse in the last year, and they met at least one of the criteria that included more than one sexual partner over the last year, or they defined their relationship status as single, or their most recent partner they reported was someone other than their primary partner, or they've been in the relationship less than a year. So they targeted individuals who had a newer relationship and found that even in that group, 20% of men and about a quarter of the women reported using a condom the last time they had sex. So it does look like this condom use phenomena is less common, even amongst individuals who are perhaps not in stable relationships in the older age groups. So there's some special considerations for us to think about. There's socio-behavioral considerations that are unique to this population. We have individuals who are widowed or divorced, who are on the dating market again for the first time. Some of them in time, it's been a long time, right, that they've not been dating. There's that lack of condom use that we talked about, and that can be due to a variety of factors. When they've performed qualitative studies of this, there seems to be a lack of risk perception, and also just a lack of knowledge about STIs and HIV that could be in their community of the individuals they're picking partners from. There's no pregnancy concerns to worry about. And then there is an unbalanced gender ratio as you get older. And that tends to be a theme in STI and HIV research, that when more women are competing for fewer males, the condom use issue becomes more difficult, that negotiating power that may be playing into it. In addition, the risk assessment and screening may not be occurring on a regular basis due to assumptions that we make as providers, so we may not bring it up, and also the patients feeling like they don't want to bring it up because they're stigmatized. Then we have the biological issues, and so we know these erectile drugs have prolonged, they probably contribute somewhat to this prolonged sex life that we're seeing. And then we have, for females, the thinning of the vaginal mucosa as a result of menopause and the dryness there that predisposes women likely to trauma and also acquiring STIs. You have some inflammation there, some irritation there, some breaks, some microabrasions that, at least from a theoretical point of view, could put a woman more at risk. And then there's some studies showing there may be some immune changes in the cervix, that menopausal cervix, that put a woman more at risk for HIV acquisition. So you do have some biological issues going on as well. So let me talk a bit about HPV and give you guys an example. HPV is the most common STI that we have. 85% plus of us will acquire at least one strain in our lifetime. We know that. Most of us will never know that we acquired it. It will go away and we'll never be, the worse for it. It's more common in the 20 to 24, 25 age frame, and when the vaccines were developed, they were tested in people 26 and below, or 9 to 26 years of age, and part of that was based on earlier data that showed that women did not tend to acquire new HPV strains later in life, and also the ones that they did acquire were not really the vaccine strains that were being looked at. However, a recent study evaluated high-risk HPV infections in a higher risk cohort of women, 25 to 65 years of age, and the investigators in this situation recruited these women from an internet-based study, and these were women that were online dating. Now, a lot of that online dating is going on these days, right? The women have completed questionnaires, they did self-obtained vaginal swabs, and they checked these swabs for HPV DNA PCR, including 19 high-risk HPV types. They ended up with 420 women in the study with a mean age of about 36, plus minus 10 years. And they reported a median number of 11 male lifetime partners. About half of the women had had a new partner or multiple partners in the last 6 months. So that just gives you an idea of the population. And they found in this particular group a cumulative incidence of high-risk HPV of 25%, and did find that the HPV 53 and 16 is a big player in cancer, whether it's the throat, whether it's the anus, whether it's the vulva or the cervix. The more we learn about it, the more we respect type 16. But those were the more common types. They also were able to calculate, based on the history, that about 64% of these new infections were due to the sex partners. And this was higher than they had calculated in previous studies that had shown that women didn't tend to continue to acquire these infections. And there were more vaccine-covered types than they had appreciated before. Now, they did find in the women who did not report recent sex partners that their history of the number of lifetime partners predicted HPV detection in them and incident HPV detection in them, and the thought is that there was also some reactivation of latent HPV that was going on as well. But this, we still have a vaccine that goes up to the age of 26, but I think in the research world we're starting to reevaluate that, also particularly for MSM, because there's data, at least out of Australia, showing that the acquisition of high-risk types that continue on later into life. But it hasn't changed yet. So what do we do? What are the recommendations in terms of STI screening? I love this cartoon. So the bottom line is that there's really not, I mean, besides HIV testing, and you know, everyone should have an HIV test between 15 and 64 regardless of risk. Okay, and that's a grade A recommendation. And then annually if they're at risk going forward. But for the other STIs, there's really not, there's no screening recommendations out there for older populations. So gonorrhea, chlamydia, syphilis, trich, all of that's going to depend on talking to the patient and figuring out what's going on with them and whether they need to be tested. So that, yes. Mm-hmm. My understanding is insurance companies pay for it because it's I always get the acronym wrong, but it's like the highest recommendation. Okay, whether people are doing it, I can say no. Okay, because I'm on the other end in the hospital occasionally with an AIDS patient who had so many interfaces with the healthcare system. Unfortunately, that's still happening. So it, you know, and we are human, you know, providers human. We still kind of, I think, tend to look at people and say, you know, you're not at risk, so, and don't bring it up. But that's why I'm going to get into this part, the sexual health piece, as a way to talk about some of these things, because it can be helpful. Primarily because we have some common concepts about STDs that we have to deal with, that they're a result of inappropriate behavior, that people will know when they have them, they'll be symptomatic. Historically, efforts have focused on women. It's been something that's affected us, not us, but others, and that they're not appropriate for conversation. And this has affected, and I'm going to skip through some of this because I'm getting low on time, but it's affected how we interact with patients, okay, and how people are screened and seek care, et cetera. So by taking a sexual health approach, it encompasses more of the whole lifespan of the patient. So it's not just about STD HIV risk. It's more of, you know, just the general approach, starting with hepatitis B vaccination of the baby at the time of birth, okay, because that's a vaccine really for an STI in this country. Sex education, family planning, interpersonal relationships which drive a lot of this. And also, later in life, erectile dysfunction, diminished desire, vaginal dryness, which can be the bane of women's existence, etc. Okay, so it can really just, you know, encompass a broad umbrella and therefore be normalized conversation and destigmatized to the patient and the provider if it's really talked about every time and not just individuals, if you follow what I mean. If it's just part of the practice, it gets to be something that's just standard, both to you and the patient. Part of this has to do with using gain frame messages instead of loss frame. So, for instance, loss frame and how you approach a question, for instance, would be, have you ever had homosexual sex? Okay, versus, are your partners men, women, or both? Okay, it just allows people to be able to open up a bit better. Or determining sites of exposure. Have you had oral or rectal sex or just regular sex? Okay. Versus have you had, when you have sex, what sites get exposed? Now, a patient may feed it back to you that, oh, I only have regular sex. But then when they do that to me, I'm like, okay, well, tell me what regular sex is to you. Because the more you start talking about this, it's kind of interesting. Some of the stuff you find out and how people perceive different things and what they're doing, too. But by having that more general approach or a positive approach, it can help people to open up to you. So let me go through an actual case. This is a 69-year-old male who had a past medical history significant for prostate cancer. He'd had his prostate removed 8 years previous. In his chart was no sexual activity for 8 years. That was all throughout his chart. He came in with a chief complaint of a non-painful rash on his penis for 2 weeks, no other signs or symptoms. His doc gave him some antifungal cream, and the rash resolved. And this is a picture of the rash. Then he returns to clinic 3 months later for boils on the butt. Okay, that's his paraphrasing. And he noticed that he wiped, he had some blood on his tissue, and he got his mirror back there, and he didn't like what he saw. His primary care doctor didn't like what he saw either and referred him for colonoscopy. The colonoscopy was negative for polyps and malignancy, but the GI docs didn't like what they saw either and sent him to the GI surgeon. The GI surgeon was concerned about squamous cell carcinoma of his anus and resected the lesions. And we got a syphilis diagnosis out of that, okay? So what went wrong with that? Because if you think about what that patient went through, he went through conscious sedation, full-on, total sedation. I mean, he, went to the OR. He could have had an RPR. When we kind of went back and looked at this, it was true he had not had penetrative vaginal or anal sex in 8 years because he could not achieve an erection after that surgery. But he participated in oral sex quite a lot and had had sex with approximately 6 female sex workers in the 6 months leading up to the initial presentation. He exchanged sex for drugs. He did not use barrier protection because he did not think oral sex was risky like a lot of Americans don't. And he even mentioned, he says, one of those women had a rash all over her too. I mean, he said that afterwards. I was like, oh my God. Part of it was that perception of what sex is and what can be done for people to achieve intimacy, I think. And so this guy had figured out another way that he did things. And it had put him at risk for this. He was very relieved when he found out, because by the time he was referred to me, what they had resected and what you saw on his bottom was condyloma lata, the lesion of secondary syphilis. And the lesions had come back over his surgical scars by the time he got to me, because no one did the RPR till the path came back. And he was so relieved to find out all he needed now was some BIC, some bicillin, and that he didn't have to go back to the OR or something. So let's go through some basic concepts on sexual history and risk assessment, because these are some issues that cut across all age groups. And it doesn't have to be complicated because not everyone's going to need a really in-depth assessment. There's a few questions that could be asked on the front end to figure out who needs more in-depth questioning. So, like, for instance, when's the last time you had sex? Now, if someone says it's been 10 years, you may want to explore that for other reasons, right? Not from an STI risk point of view, but maybe there's some other things, because sex is important to us as human beings. And so that may have, there may be some other things that can be done there. How many partners have you had in the past year? Were they men, women, or both? And then once you get the answers to that, you'll have a sense as to, okay, do I need to delve deeper into this? Don't hesitate to screen if you decide that, that person, they would benefit from that. That is not judgmental, it's health promoting, and it can be framed to the patients that way. And then routinely provide STI prevention messages during continuity care. And once the patient gets used to hearing it from you, they expect it. Okay, it's just part of the routine. So some things we could ask. Ask about various types of activities. So tell me about how you have sex, and then see what they say. That can always be a bit interesting. Then if they don't open up, then I usually will try to kind of pin down exactly what types of sex they're having, because that tells me where I need to screen them. So, okay, what types of sex are you having? Is your vagina exposed? Is your bottom exposed? Is your mouth exposed? And I even say it like that, because if I ask, are you having oral sex, the directionality and exposure of that gets to be confusing in terms of whether I need to actually screen the throat of my patient, if that makes sense. Knowing that is important, particularly for men who have sex with men. Multiple studies now have shown that we miss infections when we don't screen MSM at extragenital sites. This is just one of these studies that shows that the proportion of men with a negative urethral test, so of the men that had a positive pharyngeal gonorrhea, over 70% had a negative urethral test. And then if we go to the other end of the graph, of those who had a positive rectal chlamydia, almost 90% had a negative urethral test. So the urethral screenings, those lovely, convenient urine gnats, which are great to use nowadays, don't cover all our bases if they're exposed at other sites, particularly for MSM. All right, so let's do another case here. This is a 60-year-old man. He has well-controlled HIV. He came to clinic without symptoms. He reported 8 male partners over the past 2 months. He does not use condoms for oral sex. He always uses condoms for insertive anal sex. And then he's been carrying around these female condoms for receptive anal sex, but he hasn't used them. On the exam, you notice this rash, and then appropriately you treat him with 2.4 million units of bicillin because you're concerned about secondary syphilis, and his RPR comes back a couple days later and it's 1 to 128. One of the points, this is not really elderly specific, but if you think you're seeing a primary or secondary syphilis manifestation in someone in clinic, safest to go ahead and treat them. And I always frame it that it's safest for you if I treat you. You know, we can work it out with the blood tests later, but unfortunately people leave the clinic and continue to have sexual contact, and they're infectious. So from a public health point of view, it's really important to get these people treated before they leave the clinic. So I kind of gave you the answer here. In terms of the stage of change that he was in for unprotected receptive anal sex, he was actually in preparation for that one. Okay, so what I'm trying to do at this point here is just highlight how we can figure out, from a counseling perspective, kind of how to break this down a little bit, because it seems overwhelming, and that I always identify with that face in clinic sometimes. So we know that across the board, whether it's STI HIV issues, whether it's obesity, et cetera, the effective behavioral interventions include tailoring the message to the patient and their circumstances. It's interactive, it's based on their circumstances and their readiness to change, uses a harm reduction approach. And part of the techniques can include, kind of eliciting from them their dissatisfaction with the status quo, getting them to say, why this is maybe not okay with them anymore, or how it's impacting their life in a negative way, the advantages of change, the intention to change, kind of looking back to see how things have affected them in the past, and looking forward to how things would be if they changed the behavior, but kind of exploring all of these issues, including goals and values. So just some concrete steps would be summarizing the risk behavior. So in this particular example, it would be like sexual risk behavior, but there could be any other behavior. What are they doing, and who are they doing it with, actually? So type of partner, main or casual partner, actually plays into their willingness to take protective behaviors, actually, in the STD world. And that can be important to include in the counseling or to think about with the patient. And then how? Are they using condoms? Are they using substances while they're having sex that's affecting their decision-making? Or is their partner a certain HIV status, and that's affecting their decision-making? Because there's a lot of risk stratification that goes on in terms of decision-making with that, particularly in the HIV-positive population. And then assessing their perception of risk, okay, would be the next step. What concerns do they have about getting an STD or hepatitis? Actually, hepatitis tends to worry my HIV patients more than other things, particularly Hep C for MSM. And what do they see as the riskiest things they do now? These are just some examples, okay? It's not all the things you could do. And then it would be assessing the readiness. So I've just given this box here as an example. And these are the stages of change. I'm sure you're familiar with these. Smoking cessation, that's most famous for that. But Prochaska's stage of change. And for instance, in preparation, this guy was ready for action. He's carrying these condoms around, but he hasn't done this. He hasn't enacted using condoms for receptive anal sex yet. So you would assist in his goals, teach him skills, or maybe something he's having issues with using them. He may not feel right using for instance, the female anal condom for anal sex, or developing a plan. So that might be where he would be at with that stage. Whereas if he was in the pre-contemplative stage, like I don't even have a problem, that would involve more consciousness raising. The things that we as providers do more naturally, like just the impact of the behavior and the risk and this, that, and the other. Unfortunately, that strategy doesn't work for everybody in every stage. So this table breaks it down on some strategies that help people in other stages of change. And then negotiate a goal. And generally, it's just one behavioral goal you want to target so that they're not overwhelmed, and you want to probably go with the one they're most ready to change, even if it's not the one you're most ready to change. Okay, because if they achieve success with that, then that gives them some self-efficacy to then take on something different, and then follow it up at the next visit. So that was I kind of was fast with all of that because I don't want to get into the next speaker's time, and I wanted to allow time for questions. But before that, I wanted to let you guys know of some resources out there. So we have the STD treatment guidelines that are there on the CDC website, and there is an app that you can download on your device. I use it in clinic. There's a FAST, you can look at just the FAST recommendations where you just put in gonorrhea and it just tells you the treatment, or you can pull up the full guidelines if you were so inclined to read them. Okay, and so that's an option. There's an STD clinical toolbox option. We have a consultation line now, the National Network of Prevention Training Centers does, that's available at that website. And that's kind of a warm line. If you have a question, you can enter it, say how long you need, within what time frame you need an answer, and then it taps into the experts around the country that are in this network to get you an answer to the question. And then the last thing I want to tell you about, we just launched the National STD Curriculum a couple months ago, and this is an absolutely beautiful curriculum, so just check it out. It's like a joy to look at. I don't know for you guys in training if, I grew up on Netter as a medical illustrator. We used to say Netter is better in med school, but the medical illustrator for this curriculum rivals Netter. Okay, but it also the quality of the data and everything, and the interactive component, I would just urge you to look at it. And also for supervisors, you can enroll the people, the staff that work with you, and you can track their progress too. So it's interesting. I'm not going to go through all the slides with that, but just leave you with that website.